Whether you are at home or at work, there is always the chance that a medical emergency, such as a heart attack, cuts, burns, etc., may occur. Medical emergencies can range from minor to major incidents. Basic first aid knowledge can help you be prepared for helping with a variety of medical emergencies and help you assist victims while emergency medical services are contacted and until they arrive. In this lesson, we will cover the definition of first aid, common situations where first aid may be required, and what to do when first aid is needed. For more information on first aid, please refer to our other first aid lessons. The term first aid is defined as the emergency care or treatment given to an ill or injured person before regular medical aid can be obtained. According to OSHA, first aid often consists of a one-time, short-term treatment that requires little technology or training to administer. When providing first aid, it aims to do three things: preserve life, prevent further harm, and promote recovery. Common accidents and emergencies where first aid may be required include, but are not limited to, anaphylaxis or anaphylactic shock, bleeding wounds, burns and scalds, choking, drowning, electric shock, fractures or broken bones, heart attack, and insect bites or stings. If you do not feel comfortable providing first aid, seek assistance from others who may feel more comfortable or who are first aid trained. Ask if anyone is CPR certified. People can receive training and certification for first aid and CPR from the American Red Cross or similar organizations. Before you provide any first aid assistance to a victim, you should assess the situation to assure your safety. When assessing a situation, you should do the following. Visually assess the scene for any identifiable hazards or other potential dangers. Hazards and dangers can include, but are not limited to, fires, downed power lines, flooding or fast-flowing water, chemical fumes, falling or flying debris, vehicles, violent people, or aggressive animals. Identify how many victims there are and either contact or have someone else contact 911. If there are multiple victims with differing degrees of consciousness and injuries, victims may need to be triaged. Finally, if you have deemed it safe to provide aid, either retrieve an available first aid kit or have someone retrieve the first aid kit for you. Once you have deemed it safe to aid, you should do the following. Check the victim or victims to see if they are conscious and alert. To do this, you can ask questions to see if the person responds, see if the person responds to touch, and see if the person responds to pain. If the victim or victims appear responsive and are breathing safely, you should conduct a rapid whole-body check. This includes checking for open wounds, deformities, swelling, and medical alert tags advising of underlying conditions that the victim may have. Keep the victim calm. Inform the 911 operator about any identified wounds or other injuries that you noted during your whole-body check. Provide as much information as you can, as the 911 operator can relay important information about the victim's condition to the EMS providers. Follow the 911 operator's instructions if they are provided to you. If available, use personal protective equipment such as gloves, eye protection, pocket masks when providing treatment. If you're not speaking with or being provided instructions by the 911 operator, continue to provide care to the best of your ability until the emergency medical services, or EMS, arrive. And wash your hands thoroughly after providing treatment. If a victim is unresponsive, you should follow the first aid ABCs, which include A for airway. A blocked airway can make it more difficult for a victim to breathe. The airway can be kept open by placing one hand on the victim's forehead, gently tilting the victim's head back, and carefully raising their chin. B for breathing. Once the airways have been opened up, determine if the victim is breathing normally by placing your ear directly above the person's mouth while looking down at their body, checking for the following breathing signs like sound of breath, feeling the victim's breath on your cheek, or seeing the victim's chest moving up and down. These steps should be continued for only 10 seconds, and if the victim is not breathing, rescue breathing should be performed. And C for circulation and compression. Check to see if the person shows signs of blood circulation, such as a pulse and/or a difference in skin colorization from normal. If you can't find a pulse and you are trained in CPR techniques, you should begin CPR on the victim until help can arrive. If you're not trained in CPR, you should seek immediate assistance by yelling for help or send someone to seek help while you stay with the victim. To conclude, knowing how to provide basic first aid can help you stay calm when there is a medical emergency. How you respond to an incident will depend on your level of confidence in your skills and the responsive or unresponsive state of the victim. First aid can help buy the victim time while emergency medical services arrive. If you have questions about first aid procedures or your company's first aid kit, please speak with your supervisor. I'm Olivia, your safety trainer, reminding you to be careful and stay safe out there. Thanks for watching. If you liked this video, please visit our YouTube channel for more safety training. Also, follow us on social media for OSHA updates, free safety webinars, reminders on safety tips, techniques, and more. What are you waiting for? Like, follow, or subscribe today. And stay safe out there.
Throughout this entire presentation, one thing is going to be very, very common, and that's the approach. So for every sick patient, every patient who looks to unstable to you, who may have impending sort of, life-threatening complication, would imply that you approach them to the ABCD approach. How do we manage actually with the ABCD approach? As you can see on the screen, any patient who's talking to you, maybe, if you're interacting with him and he's replying you back, the airway is patent. If he's not replying back, or you have additional sounds in the form of gargling, or any other form of snoring, so these stridor. These indicate that the airway has been compromised. The compromisation could be because of a foreign body, because there may be some vomitus, there may be some cervical spine trauma. We don't know the exact reason when you see a patient. Most of these patients would be either unconscious, brought in with a trauma, whatever the case may be. If the airway is not patent, you have to insert an advanced airway. A GCS less than 8 with a compromised airway, you have to go and insert an advanced airway. So, for instance, now a patient comes to you and who's constantly snoring. Okay, how do you approach him? So you do a very, very basic thing which we call as a airway maneuver, you change the position of the airway basically. So what do? Either you do a head tilt chin lift or you do a jaw thrust. Jaw thrust should be done if a patient is of any trauma and you're suspecting a cervical injury. Otherwise, you could do a head tilt chin lift. For instance, you think that the patient might be having blood or vomitus or something in his mouth, you could do a suctioning of the oral airway with a suctioning machine. Basically, if you don't have any suction machine, just leave it. Okay, don't do a blind basic, suctioning or blind finger insertion to looking for the foreign objects. And after you've done this, please start patient on the oxygen if the patient looks to have a compromised airway. We come to the breathing now. So for every breathing, you need to check how is the breathing rate going, how's the breathing pattern, the breathing effort, whether the patient looks cynosed, whether he's using the accessory muscles, how is it overall going. So basically, after you've done this, the inspection, palpation, percussion, auscultation, everything, yes, go ahead with it, no worries. But make sure that if the patient looks cynosed, if the patient is not breathing, these are the warning, the red flags for us. So if you've got a saturation probe, just put it on the saturation probe. During the COVID era, the slow sats, the happy hypoxia was a very, very mysterious concept, but that's only for COVID. For all other diseases, which still say just check the sats. If the sats are low, you have to supplement some oxygen. If the patient is not breathing, you have to start giving artificial respiration to the patient. If you can't find an air entry on one side, for instance, the patient had a trauma or something, if you find that the trachea is not central, it's moving to one side, always suspect a tension pneumothorax. If you can, order a chest x-ray, get a ABG. But if you're sitting in a periphery setup and the patient comes with this, and you are very sure that this could be a tension pneumothorax, just do a needle decompression. That's it. We come to C, which is circulation. Circulation, you just see the patient. If the patient is bleeding, how the patient is, what's the color of the patient? Whether the patient looks mottled, he looks pale, how's the overall condition of the skin. If the patient is cool, he's warm, sweaty, dry, just auscultate the heart, just see, no one is going to ask you what sort of murmur are you hearing. But if you can hear no heart rate, that's a warning sign. If you can hear that the heart rate, you can find that the pulse is very low, very high. These are the warning flags that you need to be, taking care of. So do a capillary refill time. It's more than 3, things should be settled. If it's more than not, if it's going more, it's not bad. So if it's less than 3, it should be normal. If it's more than 3, it's very abnormal. Meanwhile, also check the blood pressures, pulse, and ECG of the patient if possible. ECG is very, very important. It gives us a lot of information. Plus, while you're assessing the circulatory parameters, if you find that the patient has any of the unstable signs, the red flags, just get an IV line in place, get some bloods, draw some bloods, start some IV fluids. If you can't get the IV access, for instance, like in the UK, they use a lot of IO access. Any patient who's coming in crashed with a road traffic accident, you can't file the peripheries, you can't find the IV lines. They directly go for intraosseous access. In India, we still don't do it much. So once you've done the 12-lead ECG, get the blood tests, get the urinary catheter. Like if your patient is unconscious, if the patient looks to be in shock, and looks septic, toxic, just get a catheter in. If not, no one's gonna tell you, but if you can, it improves our overall management of the patient. If you can, get an echo, a fast scan, whatever. If you don't have, no worries. Once you've done the circulatory check, you go for the disability check. You check basically whether the patient is alert, getting response to your voice, pain, or unresponsive, that we term as AVP. You check the pupils of the patient, check about the neck stiffness of the patient. One more thing in a disability, we all would go and bombard the patient with GCS, calculate the GCS, but most of us would forget about the blood sugars. Diabetes is becoming a rampant disease in India. So many patients who are unconscious, hypoglycemia can also be the reason. So don't forget about it. If the patient looks to like unresponsive to you, or the GCS is less than 8, but the patient is breathing well, the circulatory parameters are well, just put them on a recovery position. Then I would come back to the exposure. So expose the patient, which we usually don't do in India. So expose the patient from head to toe. Look for any abnormal signs, any bruise, fatigue, bleeding signs, any lesions, burns, anything out of the blue. Just check it. While you're doing the exposure, make sure that you maintain the temperature of the patient. What we do is we usually expose the patient. For instance, a patient had a road traffic accident, we expose them, and the hypothermia clicks in, and then it makes things more complicated. And if you're suspecting that the patient might be having underlying sepsis, ask for blood cultures. If not, give antibiotics. If not, proceed ahead. So this is the common pathway that we'll be dealing with.
Good day everyone. It is nice to see you again. Welcome to our Any Learning, as our learning community. Lesson 3. Care of clients under emergency situation. Environmental emergencies. Increased interest in outdoor activities such as running, hiking, cycling, skiing, and swimming has increased the number of environmental emergencies seen in the emergency department. Illness or injury may be caused by the activity, exposure to weather, or attack from various animals or humans. Some examples of environmental emergencies are the following. 1. Heat cramps. 2. Heat exhaustion. 3. Heat stroke. 4. Frostbite. 5. Hypothermia. 6. Submersion injuries. 7. Stings and bites. 8. Airway obstruction. 9. Injuries to bones and joints. And 10. Abdominal injuries. Heat cramps. Heat cramps are caused by the loss of body salts, fluid and electrolytes during sweating. Low salt levels in muscles cause painful cramps. Heat cramps are severe cramps in large muscle groups fatigued by heavy work. Cramps are brief and intense, and tend to occur during rest after exercise or heavy labor. During assessment, you can observe the following to the patient: nausea, tachycardia, pallor, weakness, profuse diaphoresis, muscle spasms, and pain usually in abdomen, arms, or legs. Interventions include the following. Cramps resolve rapidly with rest and oral or parenteral replacement of sodium and water. Elevation, gentle massage, and analgesia minimize pain associated with heat cramps. Instruct the patient to avoid strenuous activity for at least 12 hours. Discharge teaching should emphasize salt replacement during strenuous exercise in hot, humid environments. You can also recommend the use of commercially prepared electrolyte solutions, for instance, sports drinks. Heat exhaustion. Prolonged exposure to heat over hours or days leads to heat exhaustion. Heat exhaustion is the body's response to loss of water and salt from heavy sweating. During assessment, you can observe the following to the patient: fatigue, nausea, vomiting, extreme thirst, feelings of anxiety, hypertension, tachycardia, elevated body temperature, dilated pupils, mild confusion, ashen color, and profuse diaphoresis. Interventions for heat exhaustion are the following. Begin treatment by placing the patient in a cool area and removing constrictive clothing. Monitor the patient for airway, breathing, circulation, including cardiac dysrhythmias caused by electrolyte imbalances. Initiate oral fluid and electrolyte replacement unless the patient is nauseated. Do not use salt tablets because of potential gastric irritation and hyponatremia. Initiate a 0.9% normal saline intravenous solution. If oral solutions are not tolerated, an initial fluid bolus may be needed to correct hypotension. Place a moist sheet over the patient to decrease core temperature through evaporative heat loss. Consider hospital admission for the older adult, the chronically ill, or those who do not improve within 3 to 4 hours. Heat stroke. Heat stroke, the most serious form of heat stress, results from failure of the hypothalamic thermoregulatory processes. It is a medical emergency. The patient has a core temperature greater than 104 degrees Fahrenheit or 40 degrees Celsius and increases rapidly within 10 to 15 minutes. Death from heat stroke is directly related to the amount of time that the patient's body temperature remains elevated. Signs and symptoms are the following: increased sweating, vasodilation, and increased respiratory rate. The body's attempt to lower temperature, deplete fluids and electrolytes, specifically sodium. Altered mentation, circulatory collapse, skin is hot and ashen. and neurologic symptoms such as hallucinations and loss of muscle coordination. Take note of this one. Monitor the patient for signs of rhabdomyolysis, a serious syndrome caused by the breakdown of skeletal muscle. The muscle breakdown leads to myoglobinuria, which places the kidneys at risk for acute kidney injury. Carefully monitor the urine for color, for instance, tea-colored, amount, pH, and myoglobin. First aid and interventions for heat stroke are the following. Place worker in shady cool area. Loosen clothing. Remove outer clothing. Fan air on worker. Cold packs in armpits. Stabilizing the patient's airway, breathing, circulation and rapidly reducing the core temperature. Administration of 100% oxygen compensates for the patient's hypermetabolic state. Ventilation with a back valve mask or intubation and mechanical ventilation may be required. Correct fluid and electrolyte imbalances. Initiate continuous ECG monitoring for dysrhythmias. Various cooling methods are available, such as removing clothing, covering with wet sheets, and placing the patient in front of a large fan. Evaporative cooling, immersing the patient in a cool water bath, conductive cooling, and administering cool fluids. Aggressive temperature reduction should continue until core temperature reaches 102 degrees Fahrenheit or 38.9 degrees Celsius. Patient and caregiver teaching focuses on how to avoid future problems. Provide essential information regarding proper hydration during hot weather and physical exercise. Instruct patients on the early signs of and interventions for heat-related stress. Take note. Closely monitor the patient's temperature and control shivering. Shivering increases core temperature because of the associated heat generated by muscle activity and complicates cooling efforts. Chlorpromazine, Thorazine, IV is the drug of choice to control shivering. Antipyretics are not effective in this situation because the elevated temperature is not related to infection. Frostbite. Frostbite is true tissue freezing that results in the formation of ice crystals in the tissues and cells. Peripheral vasoconstriction is the initial response to cold stress and results in a decrease in blood flow and vascular stasis. We have two types of frostbite. 1. Superficial frostbite, and 2. Deep frostbite. Superficial frostbite. It involves skin and subcutaneous tissue, usually the ears, nose, fingers, and toes. The skin appearance ranges from waxy pale yellow to blue to mottled, and the skin feels crunchy and frozen. The patient may complain of tingling, numbness, or a burning sensation. Handle the area carefully and never squeeze, massage, or scrub the injured tissue, because it is easily damaged. Remove clothing and jewelry, because they may constrict the extremity and decrease circulation. Immerse the affected area in a water bath, 98.6 degrees to 104 degrees Fahrenheit, or 37 degrees to 40 degrees Celsius. The blister should be debrided and a sterile dressing applied. Avoid heavy blankets and clothing because friction and weight can lead to sloughing of damaged tissue. Administer analgesia and tetanus prophylaxis. Deep frostbite. It involves muscle, bone, and tendon. The skin is white, hard, and insensitive to touch. The area has the appearance of deep thermal injury with mottling gradually progressing to gangrene. The affected extremity is immersed in a circulating water bath, 98.6 degrees to 104 degrees Fahrenheit, or 37 degrees to 40 degrees Celsius. After a warming, the extremity should be elevated to reduce edema. Intravenous analgesia is required in severe frostbite because of the pain associated with tissue thawing. Provide tetanus prophylaxis. Amputation may be required if the injured area isn't treated or treatment is unsuccessful. Hypothermia. hypothermia, defined as a core temperature below 95 degrees Fahrenheit or 35 degrees Celsius, occurs when heat produced by the body cannot compensate for heat lost to the environment. Wet clothing increases evaporative heat loss to 5 times greater than normal immersion in cold water, for instance, near drowning. Older adults are more prone to hypothermia because of decreased body fat and diminished body's response. We have 3 types of hypothermia. 1. Mild hypothermia. 2. Moderate hypothermia. And 3. Severe hypothermia. Mild hypothermia. Temperature is ranging from 93.2 degrees to 96.8 degrees Fahrenheit or 34 degrees to 36 degrees Celsius. Usually have shivering, lethargy, confusion, rational to irrational behavior, and minor heart rate changes. Moderate hypothermia. Temperature is ranging from 86 degrees to 93.2 degrees Fahrenheit or 30 degrees to 34 degrees Celsius. It causes rigidity, bradycardia, slowed respiratory rate, BP obtainable only by Doppler, metabolic, and respiratory acidosis, and hypovolemia. Severe hypothermia. Temperature is at or below 86 degrees Fahrenheit or 30 degrees Celsius, makes the person appear dead, and is a potentially life-threatening situation. Metabolic rate, heart rate, and respirations are so slow that they may be difficult to detect. Reflexes are absent, and the pupils fixed and dilated. Profound bradycardia, ventricular fibrillation, or a systole may be present. Every effort is made to warm the patient to at least 86 degrees Fahrenheit or 30 degrees Celsius before the person is pronounced dead. Cold blood becomes thick and acts as a thrombus, placing the patient at risk for stroke, myocardial infarction, pulmonary emboli, and renal failure. Interventions for hypothermia are the following: managing and maintaining airway, breathing, circulation, rewarming the patient, correcting dehydration and acidosis. A rewarming places the patient at risk for afterdrop, a further drop in core temperature. This occurs when cold peripheral blood returns to the central circulation. Rewarming shock can produce hypotension and dysrhythmias. Thus, patients with moderate to severe hypothermia should have the core warmed before the extremities. Discontinue active rewarming once the core temperature reaches 89.6 degrees to 93.2 degrees Fahrenheit or 32 degrees to 34 degrees Celsius. Treating cardiac dysrhythmias. Patient teaching focuses on how to avoid future cold-related problems. Essential information includes dressing in layers for cold weather, covering the head, carrying high carbohydrate foods for extra calories, and developing a plan for survival should an injury occur. Kindly click the next button for part 2. Thank you for listening. Have a good day and be safe. Agyamanag.
Now, in all CPR or patient care, the most important thing to check before you ever engage in care is whether or not the scene is safe. If the scene is safe, there isn't any electrical hazards, there are no chemical hazards, there's nothing in the environment that's going to actually cause us harm, the scene can be declared safe. Along with that, it also means, does the rescuer have personal protective equipment? Gloves and a CPR shield with a one-way valve barrier to protect the rescuer from bloodborne pathogens. If the scene is safe, if your gloves are on and your shield is available, or there's no blood or body fluid in the environment, you're now ready to be able to rescue safely. As always, we're going to see that the patient is on the ground, they appear to need some help, but we don't know what's going on yet. So we call out to the patient, hey, are you all right? There's no response. Are you all right? Can you hear me? I tap and shout on the collarbone. At the same time, I'm assessing this person to look to see if they're breathing normally or not. If they're not breathing normally, chances are they're in agonal respirations. Agonal respirations is a condition where the body just hasn't stopped trying to take a breath yet. It's kind of that occasional gasp where they're trying to breathe but they can't. It's really not exchanging gases, and it's not effective respirations. We're going to consider agonal respirations no respirations at all. So if the patient is breathing abnormally or not breathing at all, we're going to make note of that. So no movement, no response, no breathing. At that point, if there's a bystander, I'm going to activate EMS or call a code. You in the plaid shirt, go call 911 and come back. I might need your help. Come on back and help me when you're done. Then I'm going to turn back to the patient, and at this point, as a healthcare professional, I'm going to check for a carotid pulse. Now you'll notice I'm finding the Adam's apple, and I'm walking my two fingers off the side of the windpipe in that valley between the neck muscle and the windpipe. I'm checking for no more than 10 seconds. But please keep in mind, this is not really the most important aspect when we prepare to do CPR. If you can't tell whether there's a pulse or not, and the patient is not breathing normally, and is unconscious, we're going to begin chest compressions and CPR. Because there's a lot of studies showing us that if you can't tell if there's a pulse after you've been trained to check for a pulse, chances are, if they're unconscious, not breathing, they don't have one. So we're going to move towards CPR. In this case, I do not feel a pulse, and I'm going to find the center of the chest, interlock my fingers, and begin my 30 chest compressions at least 2 inches deep and at least 100 times a minute. That's more than 1 a second. This is fast. It's a lot of circulatory type compressions, and it's going to become exhausting in time. And we'll cover that in just a minute. But now we're going to start our compressions. Leaning over the patient's body, elbows locked straight, fingers intertwined. I'm going to pull up on the bottom hand so that all that's on the chest is my palm. And I begin my 30 compressions. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, and 30. I'm going to get my mask, cover the nose and mouth with a head tilt, chin lift. I'm going to go ahead and give 2 rescue breaths. Both breaths went in, and 30 more compressions. 1 and 2 and 4 and 5 and 6 and up to 30 more. I'm going to continue this 30 compressions and 2 breaths until an AED arrives, or until emergency medical services arrive, or a code team arrives and takes over. If I have a bystander, I told you that this is exhausting, and it is. Every couple minutes or so, I'm going to start feeling like I can't go on, because the chest compressions are going to get less deep and less effective. If there's a bystander who could be quickly taught how to do chest compressions or already knows CPR, we're going to get them in on this to give me a break so that I can restore my own strength and hopefully then take over for them in a couple minutes so that we can continue this 100 compressions or more per minute, nice, deep, at least 2 inches deep, over and over and over to try to circulate the residual oxygen and the oxygen that we're putting in the body to try to save the brain, save the heart, save vascular organs if possible, or at least slow down the dying process so that when an AED arrives or when help arrives, we've got a viable patient that has a chance at making it out of this cardiac arrest situation. Scene is safe, my gloves are on, my CPR shield's available. Sir, can you hear me? Can you hear me? There's no response. Help, somebody help me. You in the plaid shirt, go call 911 and come back. Checking for a pulse. There's no pulse. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 12 and 13 and 14 and 15 and 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 2 more breaths, 30 more compressions. I'd continue this until an AED arrived or until EMS showed up.